Welcome back, everybody. Today's topic is about Retina Exam 101. I know this is something that all of us have struggled with in early residency. No worries though, because the skills will definitely come with time and practice. So, for all junior ophthalmology residents out there, my goal today is to give you a solid basis to build your skills on. Okay, now, before we dive into the whole retina exam thing, we need to learn how to orient ourselves first, anatomical wise. This is important because if you don't know the anatomical landmarks, everything you see in Fundus exam will feel so confusing. And questions like, where exactly am I? What am I even looking at will surely pop up into your mind. I know you've been there. We all have been there. So, in order to clear the confusion, first, I need you to think of the retina as a map that has three zones. Moving from the center to the periphery, we've got the posterior bulb, then the mid-periphery, and finally the far peripheral zone. Each zone has its own unique landmarks that will help you guide your examination, and we're going to walk through them all. So let's start with the posterior pole. The very first thing you should look at is the optic disc. That's your anchor, that's your reference point. So hold on to it. So whenever you're lost in the retina, find the disc again to reorient yourself. As you know, the optic disc is located nasally. So if you see it, then you're looking at the nasal retina. Now, if you move around two disc diameters temporal to the disc, you'll find the second most important landmark, which is the macula, and appears darker than the surrounding retina. And right at its center, you'll find the fovea, which is the point of the highest visual acuity. Okay, now go back to the disc and you will notice the retinal blood vessels emerging from its superior and inferior poles. The superior and inferior retinal vessels then further divide into nasal and temporal branches. And there is a simple way to differentiate arteries from veins. The arteries look thinner, lighter, and more reflective, whereas the veins look thicker and darker. Now, pay attention to the temporal branches because they form the third key landmark in the posterior pole, which is the vascular arcades. There is a superior temporal arcade and an inferior temporal arcade, and together they arch around the macula, almost like they're protecting it. But put in mind that the macula itself is avascular, especially within its center. We call this the foveal avascular zone because, as you know, it depends on the choriocapillaries beneath it for oxygen and nutrient supply. Okay, so let's sum up real quick. You find the disc, that's your anchor, that's your reference point. You move temporal to the disc, you reach the macula. You follow the vessels that emerge from the disc, you see the temporal arcades around the macula. And just like that, you've defined the posterior pole. This is the central retina, and this is the most important zone, clinical-wise. Why? Because most retinal diseases like diabetic retinopathy, AMD, and vascular occlusions affect this area, as you know. Okay, now moving more anteriorly into the mid-periphery, which is really just a transition zone between the posterior pole and the far periphery. So once you cross the vascular arcades, you leave the posterior pole and you enter the mid-periphery. Anatomically, the mid-periphery lies between the vascular arcades and the equator. But what exactly is the equator? Well, actually, the equator is not something that you see. It's more like an imaginary circumferential line that represents the widest circumference of the globe. So basically, it divides the eyeball into anterior and posterior halves, with roughly equal distance to the cornea anteriorly and to the optic nerve posteriorly. Now, as I said, we cannot directly visualize the equator, but we can approximate its location clinically by identifying the exit points of the vortex veins. As you know, the vortex veins are choroidal veins that exit the eye through the sclera near the equator. There's usually one in each quadrant, but there could be more. They're not always obvious, but when you see them, they help confirm your location. They appear as dark, round, or oval areas, often with a slightly swirling or radiating pattern. So, to arrange your thoughts, we have two landmarks in the mid-periphery. The main one is the globe equator, and the vortex veins will help you find it. So, when do you enter the mid-periphery? When you cross the vascular arcades. And when do you leave the mid-periphery? When you go past the equator. Clinical-wise, the mid-periphery is more challenging to examine than the posterior pole, and here's where skills really matter. It also requires good pupil dilation, clear media, and of course, patient cooperation, especially since the mid-periphery is a common site for peripheral retinal pathologies, such as lattice degeneration, snail track degeneration, atrophic holes, and retinal breaks, which can progress into RD at any time. Okay, now as we continue moving further anteriorly and beyond the equator, we finally enter the far peripheral retina. This is the most anterior part of the retina and it extends from the equator all the way to the ora serrata, where it transitions into the ciliary body, specifically the pars plana. Now, the most important landmark here is the ora serrata. It's the anterior boundary of the neurosensory retina that has a serrated or sawtooth appearance. And that's actually where the name comes from, because ora means edge and serrata means serrated. And it marks the transition point between two very different structures. First, the multi-layered neurosensory retina posteriorly, and second, the single-layered non-pigmented ciliary epithelium anteriorly. Now, the ora serrata lies approximately 5 millimeters anterior to the equator, and it's about 2 millimeters in width. And as we said before, it's not a smooth line. It is formed by sharp, tooth-like projections of retinal tissue called dentate processes. These dentate processes are separated by rounded indentations of the pars plana epithelium called ora base. And this alternating pattern between the dentate processes and the ora base gives it that classic serrated appearance. Now, there is an interesting point that I want to mention. There is a bit of asymmetry between the nasal and temporal portions of the ora serrata. The nasal ora lies about 1 millimeter closer to the limbus and appears more serrated and has broader base in the temporal ora, which makes it easier to identify clinically. On the other hand, the temporal ora is more posterior and it appears smoother and less distinct. Also, there is two normal variants of the ora serrata. First, we have something called enclosed ora base, and these are small islands of pars plana surrounded by retinal tissue as a result of the meeting of two adjacent dentate processes. They shouldn't be mistaken for retinal holes though. Second, we have something called meridional folds, and these are small radial folds of thickened retinal tissue, seen in line with dentate processes. They're mostly found in the superior nasal quadrant. Sometimes you'll see a small retinal hole at the apex of a meridional fold, just like what you see in picture A. Now, beside being an important anatomical boundary between the peripheral retina and pars plana, the ora serrata is also the site of the strongest attachment between the vitreous and retina. This area of strong attachment is what we call the vitreous base. If you recall the sites of vitreous adhesions in order from the strongest to the weakest are the vitreous base, then the optic disc margins, then the fovea and perifovea, and finally the major retinal blood vessels. Now, the vitreous base is a 3 to 4 millimeters wide circumferential zone that actually straddles the ora serrata, meaning that it's centered at the ora and it extends on both sides. So it extends about 2 millimeters anteriorly into the pars plana and 3 millimeters posteriorly into the peripheral retina. Now, because of this strong attachment, this area is highly prone to vitreoretinal traction because, as you know, even following BVD, the posterior hyaloid face will remain attached at the vitreous base, and this creates traction and might cause breaks to develop, particularly near the posterior border of the vitreous base. And this is why the far periphery is considered the danger zone, because retinal tears, retinal dialysis, and rheumatogenic retinal attachment usually originate from pathology in this region. And unfortunately, this is also the most difficult area to examine because it requires scleral depression to bring the extreme peripheral retina into view. However, the use of special angle lenses such as the Goldman 3 mirror lens can also provide a reasonably good alternative for visualizing the peripheral retina. Okay, now beyond the ora serrata lies the pars plana, which is the flat avascular part of the ciliary body. It's about 4 millimeters in width and it's surgically important. Why is that? Well, that's because it's the safest site for intraocular entry for BBV and IVI, as it's located just anterior to the vitreous base. So, the entry with the trocar or the needle should be made 4 millimeters posterior to the limbus in the phakic eyes and 3.5 millimeters posterior to the limbus in the pseudophakic eyes. This way, you can avoid damaging the lens anteriorly or the retina posteriorly. Okay, so it wouldn't be fair to finish off this lecture before giving you some tips for the dilated fundus exam. So for all junior residents out there, this is for you. As you know, there is two ways to do it: the indirect ophthalmoscopy with the 20D lens and the slit lamp biomicroscopy with the 90D lens. So let's start with the indirect ophthalmoscopy. The core principle here is very simple. Everything is opposite. What do I mean by that? I mean that the image is inverted, so up becomes down, and it's also reversed, so nasal becomes temporal. So whatever you see is actually the opposite of where it really is. For example, if you see a lesion inferotemporally, its true location is superior-nasally. Even the disc and macula are flipped. The disc is nasal in reality, but it appears temporal, and the macula is temporal, but it appears nasal. But put in mind that this opposite rule only applies to the retinal image and not the patient's gaze. So, to examine a certain retinal area, you ask the patient to look in the same direction of that area. For example, if you want to see the inferior retina, ask the patient to look down. And if you want to see the superior retina, ask the patient to look up. Now, let's switch to the slit lamp biomicroscopy. Basically, it's the same as the indirect ophthalmoscopy, which means that the image is still inverted and laterally reversed. So, in your view, the disc still appears temporal, the macula still appears nasal, the superior retina is still down, and the inferior retina is still up, as you can see here in this picture. And again, if you want to examine a certain retinal area, have the patient look toward that area. It's the same direction system. So, for the inferior retina, ask the patient to look down. For the superior retina, ask them to look up. For the nasal retina, have them look nasally, and for the temporal retina, have them look temporally. And then you can fine-tune your view by adjusting your system. So you ask the patient to look toward the area of interest, then you tilt the lens slightly toward it, and then you can move the slit lamp in the opposite direction to that area. For example, if I want to see the inferior retina, I ask the patient to look down. I tilt the lens slightly down, and I move the slit lamp up to see further inferiorly in the peripheral retina. So, if everything is the same, then what's actually different? Well, you see, what differentiates the indirect ophthalmoscopy from the slit lamp biomicroscopy is not how you orient yourself during retinal exam, but it's how you view the retina itself. Think of it like Google Maps. The indirect ophthalmoscopy is basically the zoomed out satellite view. You can see a huge amount of the retina, including the far periphery, but you lose details. On the other hand, the slit lamp biomicroscopy is like the zoomed in street view. You get a higher magnification and a better visualization of details. So basically, you'd see a magnified close-up view of the posterior bole. It is better to see the details of the disc and macula, but it will be at the cost of your field of view because it will get much smaller. So, in conclusion, for retinal localization, the indirect ophthalmoscopy and the slit lamp biomicroscopy follow the same gaze rule. The real difference is simply how much retina you can see and how much details you can see with each one of them. Okay, I have reached the end of my presentation. These are my references. Thank you all for watching. Like and subscribe for more videos like this, and comment down below which topic I should do next. You can also check my other topics. Bye bye till next time.